All right. Well, hello, everyone. My name is Iman Kwaja Reddick. We are pleased that you could all join us for this week's lecture in Volume 8 of our KnowNeuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the KnowNeuropsychology Board, as well as members of the KnowNeuropsychology Committee. Additionally, we are grateful to our International Neuropsychology Society colleagues for their sponsorship and wanted to share information about their upcoming conference. The theme for this year's INS conference is Culture and Connectivity, Neuropsychology Without Borders. It will be held in New York City from February 14th through the 17th. Before we start our lecture, one of the main goals of KnowNeuropsychology is to provide free, high-quality didactic content to our audience. Every KnowNeuropsychology and KnowNeuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. New to KnowNeuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through APPCN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Kelly McNally for today's lecture titled Brief Intervention Services for Pediatric Traumatic Brain Injury and Concussion. Dr. McNally is a board-certified pediatric neuropsychologist and associate professor of pediatrics at Nationwide Children's Hospital in Columbus, Ohio. She is the director of the postdoctoral fellowship program in pediatric neuropsychology and the associate division chief for clinical research. Dr. McNally is also the co-director of the Complex Concussion Clinic and specializes in working with youth with persistent post-concussion symptoms. Her research is focused on developing psychological and behavioral interventions for children with neuropsychological conditions. Well, Dr. McNally, we're so excited to hear from you today. Go ahead and take it away.
All right, and then Iman, can you confirm, does that look okay to you guys on your side?
That looks great.
Awesome. Well, thank you everyone for joining me today. As Dr. Reddick mentioned, I'm going to be talking about intervention services for pediatric TBI and concussion, and also just some other general neurological conditions as well. Just a little bit about my background before I get started. I am a pediatric neuropsychologist. I went to graduate school at University of Cincinnati and did some of my training at Cincinnati Children's. Then I did my internship and fellowship at Nationwide Children's in Columbus, where I've stayed on as a faculty. And clinically, I split my time between concussion and TBI, and also epilepsy and epilepsy surgery. So I'll share some case examples for delivering some intervention services in both of those populations today. I also just want to mention too that, really when I started out in neuropsychology, I didn't necessarily envision myself, being in a career of doing intervention. I sort of started off on a more traditional path of, doing neuropsychological assessment services primarily, but really got interested in intervention work with some of the clinical cases that I saw and some of the need that we, sort of still have and are still trying to develop. So I wanted hopefully to talk about just the different roles that neuropsychologists can have and have people start thinking about other potential applications of our neuropsychological knowledge. All right, so just to start, no specific conflicts of interest, just by way of funding to disclose. So funding for the TOPS implementation study that I'll talk about is funded through PCORI, and the primary PI for that is Sherry Wade. And then funding for our C-STEP intervention study is provided by the Dale and Amy Earnhardt Foundation, as well as the Ohio State University Chronic Brain Injury Institute. So I want to jump into it just by starting off with a case example. And this may be a case example that's similar to maybe some cases that you might see in your clinical practice. So this is one of the patients that I saw within our epilepsy surgery service. So this patient was a 14-year-old who had treatment-resistant epilepsy. And then he underwent an epilepsy surgery procedure, so a right functional hemispherotomy for treatment of his seizures. After that, underwent inpatient rehabilitation for some post-surgical changes that he had, including left hemiparesis and cognitive changes. When I saw him for his post-surgical neuropsych evaluation, it was several months after the surgery and after his inpatient rehab. And he was presenting with a range of challenges. So showing some issues with reduced motivation and initiation, some reduced social participation after his surgery, really some difficulties coping and adjusting to the new deficits that he had after his surgery, having some grade decline in school, missing some assignments. And then there was some just increasing family conflict around communication difficulties, mostly around getting his work done, and some of the parents really encouraging him to try to get out there more, but then that was just causing more conflict and difficulties with communicating. So we did our neuropsychological evaluation, which was pretty traditional. So we did, several hours of testing where we did full IQ assessment, and then really looking at skills in lots of different areas, sort of touching on each of the traditional neuropsychological domains that we would assess. And so actually in this case, Christian had an average IQ, but did have a split between verbal and nonverbal skills, and kind of had an expected profile of what we might see often after this type of surgery. So deficits in visual spatial skills, attention, a range of executive function, slower speed, and then those left-sided motor deficits that were more exacerbated than previous to the surgery. And then our assessment of just psychological functioning just showed some subthreshold symptoms of depression, social problems, reduced social participation, and some increasing oppositional and defiant behaviors in the household. So we did what I thought was a great neuropsychological evaluation. So we looked at, really provided this detailed assessment of his cognitive skills in lots of different areas. And had really what I felt like was a really, really great feedback session. So, kind of went through each of the domains of function. Mom was really like, yes, you really got him. This really explains why we're having all these difficulties. And, we really go through almost a whole hour feedback session. And we get to the end, which again, I thought was a great session. And Mom was like, okay, so now what? Right. And yes, we talked about different things that school could do, or we talked about, maybe putting him on a referral list for, psychological intervention services. But we really didn't have a ton to offer in terms of, additional things outside of maybe going to a speech therapist, maybe, continuing his PT. There really wasn't a lot of just family-based interventions or things that we could really offer the family with what to do right now. And especially given all this great knowledge that we had about him, how could we use that and translate that into sort of the next step? So the sort of the then what after our neuropsych evaluation. So it was really cases like Christian that got me interested in really expanding the role of a neuropsychologist into that sort of next step in doing some brief intervention. So when we think about intervention services for neuropsychological conditions, after we do a neuropsychological evaluation, it's often a big challenge in terms of that next step, or where do we refer kids for that next type of intervention where we can really help them sort of tackle some of these problems that they may be seeing. If your site is anything like ours, the access to care can be a big challenge. So there can be a huge long wait list for intervention services of any kind. So, whether that's just behavior management, general counseling, whether that's in the community or within the hospital setting, typically it's really hard to get people linked up with services right now, especially post-pandemic. And, we also know that there is a lack of availability of providers who really have knowledge of, their specific medical condition. So in Christian's case, we weren't able to find a counselor that really had experience with epilepsy, not to mention post-epilepsy surgery and post-hemispherotomy, all of those types of things. then even if we have someone who might be available, there truly are a lack of evidence-based treatments specifically for addressing some of the common issues that may come up in various neuropsychological conditions. And then, finally as well, even if we do find this perfect person who knows everything about epilepsy and really can understand that sort of, complex interplay between the medical condition and behavioral function, the family has really just gone through this whole process, like telling the whole story to you as a neuropsychologist. You've gotten to know them very well. And now then to pass that over to the next person, that is another barrier on the family in terms of, retelling their story, establishing rapport with a new provider, and just having a general comfort level with a new person. So for all these reasons, there could be some things to think about in terms of actually having the intervention being delivered by neuropsychologists. I think we hear this term a lot of, sort of put the psychology back in neuropsychology. And, I think when I was going through training, that was really a push of, my supervisor saying, you have to be a good psychologist first. And it was like, yeah. Okay. I just want to do my neuropsych. Right. And you hear this, but I think it really is true, right? That we really, truly do have this specific expertise where we can sort of leverage our knowledge of brain behavior relationships into that behavior piece, right? And into sort of how can we help kids kind of at that next step. And we really have a great knowledge of the patient and the family as well. So after I worked with Christian and his family, probably was one of the providers that knew them the best, right? I spent hours with him, hours with his family, doing both pre and post-surgical neuropsychological evaluations. So really had spent more time with them and really have this really deep knowledge of their family, how their family functioned, what behaviors were really an issue for them. And so I think, we were able to leverage that particular expertise, not only about the brain behavior piece, but also about the family as a result of our evaluation. But, delivering interventions as a neuropsychologist can be challenging. There are a lot of barriers. And first and foremost, I would say probably the biggest barrier in terms of delivering interventions is really just with our demand for services. So again, if your site is anything like ours, there is a huge wait list for neuropsych evaluations, and we are pretty much the only people that can do that, right? And so if we're spending a lot of our time doing interventions, what happens to our wait list, right? Of people waiting there for our assessment services that, again, we are really uniquely positioned to provide. We also know that, not all neuropsychologists want to do intervention. And if people are really trying to start an intervention service, there may be limited opportunities for training and support, especially if this is a new service that maybe someone hadn't had, sort of supervised experience delivering. And then, of course, there can be a lot of logistic barriers with, when do you schedule this, when you have your other evaluations and report writing and all the other roles that we have to play as neuropsychologists. So my goals for today's talk is really just to, think through the multiple roles that pediatric neuropsychologists can have. I'm going to present two different neuropsychology informed intervention programs, TOPS and C-STEP, which I'll talk about. And then give some brief overviews of how we've implemented these and how we've modified them for sort of providing this service within a neuropsychology setting. And then I want to focus on the roles that our trainees have in our programs in terms of being the people who often are those with boots on the ground delivering these interventions. All right, so starting off to talk about TOPS. So this is Sherry Wade. So Sherry Wade is a psychologist at Cincinnati Children's, and she delivered TOPS. And so there's really, over 20 years of research and development went into creating TOPS. So really starting in the late 90s when, Dr. Wade was one of the first people really thinking about kind of telehealth interventions. And so, especially now post-pandemic, we're all like, yeah, okay, we all do telehealth. But in the late 90s, this was pretty innovative to be thinking about doing, delivering these types of interventions in a telehealth mode. So really starting, again, even in the late 90s and sort of 20 years of research from going from an initial face-to-face trial, there were 5 different RCTs and then a meta-analysis. So there was all this research developing TOPS, showing that it was effective, showing who it was effective for. And now the next stage was really with kind of translating this research-based program to how can we deliver it clinically? So how can we do it not within the context of a research study? How can we actually implement this and deliver that to our patients? All right, so just a little bit of an overview of what TOPS is. So it was designed for teens and their families. It was developed to address problems that come up after traumatic brain injury. Then during the implementation trial, we've expanded that to include other brain conditions. There is family choice and clinician choice with how it is delivered. So it was developed where it could be done in a self-guided way, which we'll talk about a little bit, where there is a website and families can actually go on and go through the treatment modules on their own. And in the research setting, that was found to be an effective way to deliver this content. But the most frequent ways that we're delivering the content is with therapist guided. So having a therapist step through the modules of TOPS, and that can be done either virtually through telehealth appointments, or it could also be done in person, depending on the family's need. And there is also a Spanish language version of the website is available as well. So the basis of TOPS is really teaching kids and families the steps of problem solving, and then applying those steps of problem solving to address common issues that can occur after brain injury or other neuropsychological conditions. So TOPS is set up where there's 10 core sessions and then up to 16 different supplemental sessions. There's learning modules that the families can do online, and then there's a synchronous session with the therapist for those that are in the therapist guided modes of receiving it. And then, the web material includes didactic information about the brain conditions, videos of adolescents talking about how they've been affected, training strategies with, communication skills, and then also various exercises to help practice and consolidate skills. Here's just an overview of some of the TOPS sessions. So there's on the left are the 10 core TOPS sessions, and then lots of different options for the supplemental sessions. So, this could be a very lengthy program, and I'll talk about how we've modified it, or at least start in the process of working on modifying it so that we can deliver it in a shorter period of time. And there's just a screenshot of sort of the home base going through the different modules of what it may look like depending on how someone has progressed through the different stages in the treatment. Just a moment on the effectiveness of TOPS. So this is from the meta-analysis that Sherry Wade conducted and multiple members of the team that have been involved with the TOPS program over the years. And again, there's been lots and lots of studies on it, but really the meta-analysis showed that, TOPS could be effective at addressing behavioral issues and executive function issues, both at around the time of delivery, but then also that the treatment effects were still there at 18 months and actually became a little bit more apparent in the long run. So this is hopefully showing that, families are really learning those problem-solving strategies and then integrating them. We also saw that there was no differences in efficacy based on race or gender, and that children from lower socioeconomic backgrounds actually benefited more in terms of help with externalizing behavioral issues. They also showed that TOPS was effective with even caregiver distress as well. So particularly caregivers from lower education or lower income backgrounds actually reported greater improvements of their own depression and distress from them participating in TOPS for their children. So now the project is at the clinical implementation phase. So we are sort of one of many sites. So there's lots of different sites around the country. This is actually probably not even most up to date because I think additional sites are being added over time. And so we're one of many sites that are actually working to implement TOPS and sort of deliver it as a clinical service in our clinics right now. So at Nationwide Children's, how we're using TOPS is really, we're using this as an intervention that we can offer to families if we're finding that it might be helpful primarily after their neuropsychological evaluation. So one of our primary referral sources is going to be, if our team is doing a neuropsych evaluation with a teen, and then they are identifying that they may have executive function challenges, based on our neuropsych evaluation, then when we're going through that feedback session, then we may integrate TOPS in terms of saying, okay, this is one sort of next step of one thing that we can do to continue to help you kind of moving forward. We also have different resources available for our clinicians to sort of integrate that as a recommendation into their test reports. And we really try to build it into the neuropsych feedback, so that we're linking sort of how can TOPS help address whatever problems maybe came up in the presenting concern for the neuropsych evaluation. So in the case of Christian, family was really focused a lot on some of the reduced social participation and really withdrawing. And so, we talked about sort of the role of their executive function challenges in terms of how that might be impacting initiation, but also how we might be able to problem solve through that with a program such as TOPS. Another way that we're getting patients or that we're referring patients over to this program is through our multidisciplinary medical clinic consultations. So at our site, we have neuropsychology built into several of our different medical clinics. So we have people from neuropsychology that are, say, in our spina bifida clinic or in our epilepsy clinic or in our concussion clinics. So for some of these patients, we might be seeing them in clinic, doing a consultation, and maybe recommending that, ultimately a neuropsychological evaluation might be recommended. However, often we may have a several-month wait list before they're able to get in for that full evaluation. And so TOPS is an option that we can offer for those families while they're on the wait list, for example. So in that clinic, we may do a brief consultation, maybe do a brief intervention, and then we may say, hey, I actually think TOPS might be something that we could do over the next several weeks while you're waiting maybe to get that full neuropsychological evaluation. We also sometimes get TOPS referrals just directly from our medical providers. So when we started offering TOPS as a service, we did some outreach to the different medical teams to help build awareness, and gave them information about, for which patients may this be a recommended treatment. So when we're actually delivering TOPS, we have our amazing trainees as being the TOPS therapists in many of the cases. And so this has worked out really well because our trainees are great, first off, and they really have that interest in expanding their skills and learning about, okay, what are some different roles that we can have as neuropsychologists, and thinking about sort of leveraging our brain behavior expertise, but in that intervention format. Also, our trainees generally have more flexibility and fewer, billing demands as a faculty person. So they may have some more options in terms of flexibility to sort of schedule in some of these TOPS intervention sessions. And then, of course, just by nature of it being a training program, we have a built-in structure for training and supervision. So what that typically looks like is really starting by sort of reviewing, there's lots of training materials available for the TOPS website. There's a TOPS training website. So really reviewing all of these materials ahead of time, then starting by shadowing and co-treating some cases together. And we have a weekly or every other week group supervision. And then there's a formal TOPS training that Sherry Wade and some folks from her team have everyone go through to get trained on actually delivering TOPS. And then we have, our trainees take on an independent caseload where we have a combination of individual and group supervision. And then for our more advanced trainees, they're involved in some vertical supervision experience as well. And, we think that, sort of being involved with, neuropsychological informed interventions can be really helpful, to meet the training competencies in neuropsychology. So obviously one of our training competencies is intervention, even for an assessment-based, training program. And so this provides our trainees with experience, developing an evidence or administering an evidence-based intervention. And most of this is done via telehealth. So a lot of great experiences utilizing telehealth in terms of providing the intervention. really helps understand the multiple roles that neuropsychologists can have, sort of fitting in with that professional identity training competency. As I mentioned, the trainees get experience with vertical supervision opportunities and also help in the sort of group supervision models. And then, really this program is really flexible. It's really designed to be delivered for a diverse patient population and really helping advocate for individual patient needs. And so in that way, it's really hitting on thinking about things that are important from a diversity and inclusion perspective as well. There are several modifications, though, that we have done with TOPS, and that we're really it's a work in progress. So, really, since we started implementing this clinically, really what we're doing is seeing what works and what works in the neuropsychology setting and what maybe have to adapt. Going from a program that was developed in a purely research setting, how do we actually implement this clinically? And so to do that, we have made some modifications to fit within our program. Primarily, this is around the timeline and sort of shortening the length of TOPS. So as I mentioned before, there's 10 core sessions and up to 16 supplemental sessions. So, even if you met with a family once a week, if you went through everything in TOPS, it could, you maybe only, it may take 6 months to get through a TOPS family. And really, when we're trying to see a higher volume of cases, we don't really have the opportunity to really do 6 months of treatment with one individual family in order to get lots of families through. And so what we've done is try to modify it where really in the first few sessions, we are focusing on just that introduction and psychoeducation in the first session, and then really jumping to that problem-solving model, right? So teaching the families the steps of problem solving right away. And then on an individual basis, choosing the sessions or the modules that are most relevant to the presenting concerns for that individual family. So we're really front loading those most important sessions in the first several weeks. And then we're really starting off with the timeline of expecting, maybe we're going to plan for 5 or 6 sessions as opposed to 10 to 20 sessions. And we're really thinking about this flexibly depending on the individual families. We've also tried doing a hybrid self-guided and therapist-guided mode. So really during the initial trials, it was done where it was either, fully self-guided, where the families are just, provided with the website and go through the sessions on their own, or doing it with a therapist. And what we've tried to do is sort of mix both of those models. So we have not been successful really at all with providing this intervention in just a purely self-guided way. So, if we just give the families the login and say, do it, they're really just not doing it, is what we're seeing. And so what we're trying to do now is sort of do a hybrid model where maybe we're meeting with them for a few sessions, teaching them the problem solving model, and then having them go off and do some of this on their own. So really that mix between, they maybe don't always need a therapist there, but maybe they can do some more on their own, and then really be flexible to meet the family where they're at. And then we've also done a lot with booster sessions. So we may do 4 or 5 sessions with the family that might help them sort of tackle the particular problem that they're working on. And then maybe we'll check in 1 to 2 months and have a session just to sort of review and see if there's any new things come up and help them facilitate sort of applying these principles and whatever new issues might be coming along. So going back to Christian from our case example, so when we saw him for neuropsychology, after the sort of the then what piece, we actually, he was one of my first TOPS intervention cases when we first started this implementation project. And, really what we ended up taking was that flexible approach with him. And this was, really almost by happenstance. So, our goal, the family's goal that they wanted to work on was social participation, because he really wasn't doing a whole lot. And so we came up with some different problem solving strategies, and he ended up getting a position as the manager for the football team, even though he was on restrictions and couldn't play himself. Which was awesome, except that he couldn't make our Wednesday 4 o'clock sessions, right? Because then he had football practice each day, which was great. So that's where we ended up saying, okay, now we've done the sessions, we've taught you guys the problem solving model. now you guys can transition to doing some more of these sessions on your own, and then maybe have a periodic check-in in a few months. And so for this family, it was really ended up being relatively brief, but solved one of their biggest problems they were having in that moment, and then gave them the skills where they could, continue to think about problem solving to tackle some of the other issues that may be coming up. All right, so I want to transition now to talk about another neuropsychologically informed intervention program that we're doing, and this is C-STEP. So TOPS was, really a longer problem-solving, intervention meant for moderate to severe TBI and also other sort of more severe neurologic conditions. And so we really, wanted to take a different approach when we're working with kids with concussion and persisting symptoms after concussion, and really thinking about sort of the biopsychosocial model when we're thinking about what might be driving symptoms post-concussion. And so this is, a little bit of a roadmap of sort of where we're at with our concussion intervention program. So really this started with clinical need, and where we started, doing a lot of neuropsychological interventions for kids with concussion. So especially when concussion really started increasing in terms of media and just, healthcare utilization for concussion really increased. We were doing a lot of these neuropsych evaluations and sort of saying, okay, maybe your neuropsych testing was fine, or maybe they performed, they were below expectations on performance validity testing, for example, or maybe we found some premorbid issues that might have been really driving their symptoms. But then we really didn't have a whole lot to do in terms of, okay, how do we help them through this? So I started seeing some of these patients with persisting symptoms after concussion just clinically. And then we really looked to the literature to, find out what would be the most helpful in sort of related conditions, and then try to apply that within concussion. So started, developing different treatment modules, and really started implementing that clinically, and started collecting some outcomes data. Then I collaborated with Dr. Tess Simpson, who's a pediatric psychologist at Children's Colorado, and we really developed a sort of more formal treatment manual and had standardized session content, and then implemented that both at Nationwide and in Colorado. And then after that, we went on to tweak the program a little bit, again, to make it even briefer, to make it so we can implement it within a clinic setting, which I'll talk about. And now we're doing an RCT looking at that shorter version of it implemented within the clinic setting. So to give a little background of what C-STEP is, so again, Concussion Symptom Treatment and Education Program is our acronym, because everything has to have an acronym, right? Or it's not a legit treatment program, right? And so it really is grounded in cognitive behavioral therapy. We're really thinking about the biopsychosocial framework for understanding persisting symptoms. It's brief, symptom focused. So right now we're really doing it mostly in 4 treatment sessions. And we're really, it's really multifaceted an approach, given that we're thinking about lots of different factors that can contribute to post-concussion symptoms. So here is a case example of Sarah. So this is, again, a typical case that we might be seeing in our clinic, where we're seeing kids with prolonged symptoms after their concussion. So Sarah was a 16-year-old volleyball athlete. By the time I saw her, she was 42 days after her concussion. So outside of that range where we would have expected symptoms maybe to just go away. So they were persisting at that point, and really impacting her in a lot of different ways. So this model here, it's kind of has a vicious cycle in the middle is what we think about it. And there's lots of arrows. It's very messy. And that's because there's lots of factors, lots of things going on that we need to consider when we're thinking about what factors might be contributing to prolonged symptoms after concussion. So we have the injury, and then of course we have, physiologic changes that, our physiologic symptoms, particularly in the acute period, but also those stress response physical symptoms as well. And that leads to a range of behavior changes. So for Sarah, she was, having a lot of headaches. So then she was napping, was not exercising, and she was previously a volleyball athlete, and then avoiding or having a lot of anxiety about returning to different activities. Then there can be a range of cognitive and emotional factors to consider. So really expectations about recovery, attribution, various coping styles, and in some cases, development of anxiety and depression symptoms as well. Then we also have just all these new stressors that may be there. So she had missed 16 days of school at the time I saw her, which is really challenging to dig yourself out of that hole. Was on restrictions, so wasn't participating in her sport. And then coming to see us and lots of people, and just having all these new stressors. And then we sort of removed her primary stress coping skill, which was exercise. And then there's also, again, other factors that could be contributing. So pre-existing symptoms, other concurrent stressors that are going on, and then in some cases some symptom reinforcement. So as stressful as it is going through the symptoms, sometimes those can be sort of reinforced, sort of avoiding something negative or getting something positive. So in the middle of this sort of cycle, we have this cycle between stress and symptoms and stress and symptoms. So at the point that we saw Sarah, she was really in this vicious cycle, and trying to break out of that was really our primary goal of treatment. So to do that, we're working with her in the C-STEP program. So there are 4 main sessions in the sort of abbreviated model that we're doing right now. And so I'll talk through each of those. So session 1 is really focused on psychoeducation as well as sleep hygiene. So really, in the first session, really our goals is really to identify all of those range of factors that might be contributing to symptoms, and really validating that, the symptoms that they're feeling are real, are really impacting them. And, but to give some education that there could be lots of different factors that could be contributing to them. So really talking about that mind-body connection and that relationship between behavior changes, stress, emotions, all of those things, how those may be contributing to your symptoms as well. Also within the first session, we really want to focus on sleep. So we see so many kids where their sleep just becomes so disrupted after their injury, and that's really driving a lot of their symptoms. And so, usually it's sort of 2 factors: poor sleep organization. So a lot of times, like in the case of Sarah, coming home and napping when they have a headache, and then disrupting their sleep at night. Just a generally low activity level as well, and just an irregular sleep schedule all can cause issues with sleep organization. Also, we have increased arousal at night, so that can be through anxiety, be through being on your phone, caffeine. So lots of things that are just pretty common for teenagers in general, but that can be amplified as someone is recovering from their concussion. So during that education session, so during session 1, we actually just go back and go through this model where we may not sort of show all of this to the family, but we may draw this, with the patient and going through in each of these boxes. Okay, what are the new stressors that you're having? How has your behavior changed? What else is going on? Are you getting anything positive out of it, right? And so we might really be going through each of these boxes and writing down, okay, what are the factors that are occurring for her, and how is this leading to this sort of self-reinforcing cycle between stress and symptoms in the middle. A big piece during session 1 is also a parent-directed piece of the intervention, and that's meeting with the family, with the parents one-on-one, and giving education to them of how they can best respond to symptoms to help support their child going through recovery. So the family engagement is super important with this intervention. So really talking to the families about eliminating status checks, so not asking about symptoms, really focusing more on functioning, trying to encourage independence and symptom management, and really, kind of making sure that we're not inadvertently reinforcing those symptoms from occurring. During session 2, what we really want to focus on is activity management. So a lot of times what we see is kids like Sarah who really withdrawn from activities and really aren't doing much at all. And then maybe they try to go out and do something, and then they're maybe pushing it too hard. That's causing a symptom exacerbation. And so then they pull back again, and that sort of reaffirms their belief that they can't do anything. And so we just sort of have this overdue, underdue cycle with our activity. So we really want to go through their daily schedule and really think about this, not too little, not too much. So how can we sort of get their activity in that like mid-level so that they're taking breaks before their pain symptoms get worse. So we're really going through and kind of problem solving, exactly what they're doing and how to sort of cope if we of things that we can do when they need to take those breaks when their symptoms get exacerbated. Also in session 2, we start doing some different relaxation techniques. So we usually teach belly breathing to start with. There's various apps that we may recommend. There's some free ones. This one is just an example of a breathing pacer that sometimes we recommend, but there's really lots and lots of different apps and things like that they can use that may help them sort of practice some of these skills outside of the clinic. Then in session 3, we do some more relaxation. So we might do other techniques such as relaxing imagery or progressive muscle relaxation. But then we also focus on thought errors. So really this relationship between the situation, some negative thinking patterns. So kind of just more classic CBT and how that can lead to different feelings and then physical sensations and then different behaviors. So really trying to target what are those thought errors and how can we maybe reappraise those or reframe those thinking styles. And then really the 4th session is really kind of rehearsing and reviewing and sort of problem solving of what's going okay, what's not going okay, what should we do moving forward, and then also identifying any future needs. So, a lot of the kids that we see in this program may have a lot of pre-existing mental health challenges. And yeah, we may not be solving all of it in our 4th session treatment, but that's not necessarily our goal, right? We want them to sort of increase their functioning and then identify if we can link them up potentially with someone if there is sort of any ongoing psychological needs. Just a little bit in terms of data. So we've had a couple different studies looking at this, just sort of doing C-STEP in a clinical setting. So the first one was just at Nationwide, and the second one was both at Nationwide and Children's Colorado. And in both times that we implemented it, we saw that, at baseline symptoms had really plateaued, and then we saw a significant reduction in post-concussion symptoms with treatment. And then along with that, we saw corresponding improvements in quality of life and then reduction in anxiety and depression scores as well, and with increased self-reported amounts of exercise and improved sleep quality as well. So who benefits? So what we saw with some of our studies is that baseline depression scores inversely correlated with symptom change. So really suggesting that maybe individuals with more significant depression at baseline might not benefit quite as much from such a short symptom focused program. They may really need some more sort of traditional treatment for depression to really, move the needle quite as much. We did see that those who started off with lower physical exercise at baseline had greater improvement. So, suggesting that this could be particularly helpful just getting people back to moving and to sort of increasing their activity level for those who've really withdrawn from activity. We saw the most significant symptom change was after that first session where we did education and sleep hygiene, but we did continue to see improvements at the follow-up session. So, suggesting if you only have one session with someone, maybe really focusing on that education and sleep could be, a great place to start. And in our samples have been relatively small, so we haven't yet found demographic predictors of who does better with this treatment, but there is a trend for time since injury suggesting just that earlier intervention is key. So what we're doing now is really integrating C-STEP that was previously done just in our outpatient clinic in neuropsychology, really implementing that now in our multidisciplinary clinic. So we have what's called our complex concussion clinic, where we are it is a multidisciplinary clinic where that involves neurology, neuropsychology, physical therapy, and athletic training. everyone who comes in on their first session, they get a brief neuropsych assessment. So just about a 30-minute assessment. And then we give some feedback and really help with school reintegration. Then there's a physical therapy evaluation who's going to focus on vestibular function and physical exercise tolerance, and then a neurologic exam as well, and medication recommendations. And so all of the providers sort of come together and develop an individualized care plan that involves some returning treatment visits. So usually 1 to 4 treatments, and that may include C-step, working with our athletic trainer, and also our physical therapist, depending on the individual. We have done some modification to sort of fit C-step within the multidisciplinary clinic. And part of that is really, integrating that neuropsychological evaluation results into our treatment and our overall conceptualization. So as I mentioned, everyone at the first session gets this really brief neuropsychological evaluation. So we can help use that to, better understand the patient as we're going through the intervention. So for example, if they present with a non-credible effort profile, that is something that we take into account with just, sort of how we're approaching things and how much we're working with families, especially on the potential role of symptom reinforcement. If they have a normal cognitive profile, that can be really helpful in terms of providing that reassurance and sort of normalizing some of their cognitive complaints and thinking about how it could be, related to lots of different things. Sometimes we're maybe identifying pre-injury cognitive weaknesses, and then we can help them problem solve that through as well. Another big bonus of doing this intervention within the multidisciplinary clinic is that we can really help them with the other aspects of their treatment. So most of these kids are also going through a graded exercise, return to exercise, or they might be doing some physical therapy exercises. So we can use our skills in motivational interviewing and goal setting and problem solving to help them improve their adherence to these other therapies that are also an important aspect of their concussion care. And then we can also help them build coping skills so they can engage better in the treatment. So for example, if when they're doing their exercise therapy, it causes a temporary, increase in their headache, that's okay. We can help them learn how to better cope with that so then they can continue to sort of take that break, but then get back to exercising as opposed to sort of fully pulling back and not, continuing with that. All right, so just to wrap up in the last few minutes, I wanted just to talk about just some general lessons learned in terms of being a neuropsychologist, sort of implementing interventions. And I think first off is that, I think we really want to focus on treatments that can be brief and really stick with treatment goals that match our neuropsychology expertise, right? So, we really want to sort of, leverage our brain behavior our brain behavior expertise in the treatment that we're providing. So I don't think we're going to be successful if we're the ones that are going to see someone for 6 months or for a year and doing general coping and adjustment. We just are not able to have that much of a caseload. We need to have it brief so we can move patients through, so we can really focus on sort of how we can uniquely help with their concerns. And really that flexibility is key, right? So if we can do things telehealth or in person, depending on what they need, if we can maybe do it a little bit shorter because they're not going to be able to come back, maybe thinking about even a single session of intervention. Okay, if we only have one session, what can we do in that moment to really help move the needle at least on one problem that they might be focused on. And then using our neuropsych evaluation findings. So I think it can really help, especially for families where they might have some stigma around participating in therapy, right? It's not therapy, it's neuropsychology, right? And so they might be really okay with that angle. And it really can help the buy-in where, again, we really know these families very well after our detailed evaluations. And so how can we use that to kind of help them problem solve and think through sort of things that could be the most helpful? We do need to think about ethical issues just with dual roles. So moving from, for example, if you were, a treating provider, then moving back into an assessor, there could be some issues with objectivity and things that might not be the best person, right? But there could be different cases where it may be okay to go from the evaluator to the interventionist, but we always think that through. Say, for example, if we've done a neuropsych evaluation, who should be the person doing the intervention? Should that be that same person, or should we, maybe if we gave them some feedback that they didn't agree with or that was challenging, maybe sometimes it could be, more appropriate to be a different provider. So we always think that through on an individual basis of, what ethical issues may come up with the multiple roles when we are kind of bridging that, the practices between intervention and assessment. And then just to mention billing and documentation. So for most of these, we're typically billing under health and behavior CPT codes. So just, to put it out there, really these codes are developed for behavioral interventions related to health problems. And so that really kind of fits nicely with what we're doing. We've done a lot of work with trying to get, specific note templates and try to increase our efficiency with documentation for this. So, there's a lot in neuropsychology that a lot of people are doing too to help improve our efficiency, but even within intervention, that's also really important. And then optimizing our medical records for clinical research. So if we're doing some of these interventions, how can we learn from our patients and maybe build our documentation so that we can pull data from that if that's something that you're interested in as a project. And then finally, just some things to think about during training. I think just going back to that, neuropsychologists are psychologists first, but actually really, I think people hear this a lot and, again, just really often just want to focus on the, assessment, because neuropsych assessment is super cool, right? The majority of what I do is still neuropsych assessment, but I think, sort of building on those core psychology skills that we learn through training is really important. And then we can, really sort of integrate both that neuro and the psychology piece. And also, again, keep an open mind. When I was in training, I definitely, again, went through my treatment practicums, but was not thinking that was going to be the direction I was going to go in, especially with neuropsychology. But, really, I think the way I got involved with some of these things was, seeing what was a barrier for our families, right? Seeing concussion patients and realizing, what do they do as their next step? And so kind of keeping that open mind with, well, maybe we can be the people that can help them with that next step. And then also just when you're in training, considering, thinking about opportunities that might exist to expose you to program development. So if your supervisors are doing different things to develop new programs or doing quality improvement initiatives or thinking about how do I, do this in actual practice, as much as you can get exposure to that with your supervisors, I think that's a great experience for trainees to think about. And then again, just thinking about the administrative details, right, of how do you bill for this? How do you figure out scheduling for this? Those are all some of the sort of practical challenges that we don't always think about as at training, at the training stage, but that are really important if we're wanting to implement this in real life. So with that, I can end my actual slides, but have some time for some questions. And hopefully I've just, given you guys some things to think about in terms of different roles that we may be able to have as a neuropsychologist. And my email's on there too, just if anyone wants to reach out about any of those specific programs as well.
Thank you so much, Dr. McNally. That was a phenomenal presentation, and I feel like I'm biased, but I absolutely love this work. I really love the role that we can play as neuropsychologists. And I think, as you were saying, that we have the training in terms of intervention, but part of what we're doing when we're gathering information, when we're giving educational information to families and discussing the results and recommendations is an intervention within itself. And I think that when you were talking about the RTCs and just seeing that from those first sessions, and even those caregivers saying that they had their own, positive changes from being involved in these sessions, that's incredible. So we have a couple of questions, but I just wanted to highlight that as well, because I think that's incredible. One thing that what came up in terms of triaging and thinking about these patients, for example, for TOPS who do have a moderate to severe brain injury, what kinds of clinical pearls do you look for to say, okay, this patient is now appropriate for this intervention? Just thinking about the recovery continuum and, the level of participation that's needed.
Yeah, no, that's a great question, and one that we've thought about a lot with, like, at what point, right? Like, if they're just leaving rehab, is that really the right time? We usually, try to do about 6 months after. I think sometimes it's hard to jump right into problem solving, when they're really just reintegrating into life. If, say, it was someone who went to inpatient rehab, for example, a lot of times, even if we're talking to them on the unit, a lot of these problems don't really become evident until they're really getting back into things and seeing how it's going to look. For the implementation project, though, we're flexible. And so if there is a family that, wants to do it sooner and knows about it, we're happy to try it. But I think typically we're thinking about this maybe 6 months to a year post, in really thinking about sort of in that more chronic phase. The other piece is usually right away, there's a lot of interventions that they're getting, right? They're maybe getting speech, they're getting PT, they're getting OT, they have a lot, I think it's the most effective for those families that now we're a year out, now we're 2 years out, and we're not doing a lot of those other therapies, and we're just kind of struggling, and there isn't that same support that they might be having more acutely afterwards. In terms of level of function too, again, we've done TOPS with kids who maybe themselves had a lot of functional impairment, and so maybe they weren't even doing a ton of the problem solving, but the parents were. And so it's been even really helpful for parents to think through the problem solving pieces too. So we really think about it as a family intervention, and that allows it to be tailored depending on how significant of functional impairments that the patient may have themselves.
That's really helpful. So kind of just as a number, 6 to 12 months post discharge, potentially highlighting the fact that they're going to be in other interventions as well. And also keeping in mind that when they get back into their daily life, there's going to be those challenges that come up as their brain is continuing to heal and they're starting to see where those weaknesses come up. That makes sense.
Exactly.
I really like how you highlighted the family intervention piece as well. And in one of your slides where you're identifying, what are the barriers, and you all, yourself and including Dr. Wade have really created this nice intervention that has just filled a huge gap, especially like you said, with those patients with lower SES and socioeconomic status and whatever else struggles that may be going on, where you were able to demonstrate from research that they're able to benefit from this intervention. So I think in terms of a diversity mission, that's really incredible that you all are able to do. The other question that came up was, and this is probably with those who are very familiar with the intervention, when you're thinking about problem solving, and some of these patients that we're seeing, they may have a comorbid, anxiety disorder diagnosis, or they may have adjustment after the fact, whatever it may be. Does it ever come up where the therapist or the trainees have to do like a fear hierarchy? Is there any kind of like bringing of other interventions into these interventions?
Yeah, absolutely. So again, like we are, especially now that we're doing this as an implementation, we're not always sticking to the manual, right? And so absolutely. Like, so we struggle with how much can we do in this sort of more brief and targeted and focused thing versus what's something that maybe it is going to be a longer process, right? And I think it is, if there's something like, a particular fear, right? We can do a hierarchy and we can help them with relaxation strategies and things like that, because again, that's within the sort of realm of, okay, what is that problem that we're trying to solve? I think if someone has a more significant mental health issue, we might be able to problem solve around it, but then we might be linking them to something for a longer term. But that's probably the biggest thing that comes up in our supervision is, what is our role and how do we, because again, it's usually multifaceted, right? There's lots of things going on for them. And so how can we stick within sort of what we're doing, but, not see this one patient for a year when then we can't get other people through. So it's this constant push and pull. So don't have the best answer, except that we think about it on an individual basis, and also just, in the individual families resources as well. So if it's like, okay, we're going to recommend, maybe transitioning to see, just a general psychologist, but we know that's going to be 8 months before we can get them in. What are some things we can do in the meantime, just as we're working with them as part of TOPS as well?
That's great. Thank you so much for speaking to that. Well, you have graciously shared your email. Thank you so much. Are there any other resources or anything else that you think would be helpful for our learners, or anything else that you'd like to share?
No, I mean, I think the main thing is if anyone's interested in TOPS or C-STEP, if you're interested in TOPS specifically, you can reach out to Sherry Wade, and I can also get you in touch with her as well. But also, if you're interested in implementing C-STEP, I'm happy to, consult. And I, talk to a lot of people about just different settings and how to implement it in different settings and things like that. So definitely I'm happy to be available if things like that come up.
Well, thank you so much. This was such a pleasure having you, and just looking forward to more people learning more about these amazing interventions from you. Thanks again.
Great. Thank you.